we're going to talk about what every doctor needs to know about repetitive strain injury. Unfortunately, not every doctor is equally educated in this area, so we have on board really the top expert in this field, Dr. Robert Markison. He's got nearly 40 years of experience as a hand surgeon. He's a clinical professor of surgery at the University of California, San Francisco. And we're just going to turn things over to you, Dr. Markison. What do doctors need to know about repetitive strain injury, diagnosing and treating?
Well, first of all, about the patient, you have to do a quick, simple, non-abrasive sincerity test to make sure that they're not somatizing unduly and rocking the baby of pain as a crutch to avoid work or engagement in life itself. Let's assume from here on in our discussion that the patient is genuine, is not the person who doth protest too much, and is interested, eager, in a positive way, without a negative self-fulfilling prophecy, in a positive way, wanting to get better. And that involves nimbleness of brain, hand, self, soul, in terms of wanting to make fundamental changes. So what the doctor needs to know is how to take a very, very detailed history. And that history, at a minimum, has to be consideration of endocrine and metabolic conditions, hand temperature, circulation, diet, nutritional status, vitamin or supplement consumption, family history of work disabling musculoskeletal and neurological conditions, history of single agent and polypharmacy related drug side effects, drug allergies, or any history of adverse drug reaction, recent and remote laboratory testing results that might be trending towards diabetes, trending towards hypothyroidism, trending somewhere, total scope of upper limb use apart from work. That could be childcare, animal care, could be driving and commuting long distances, history and current status of vis-a-vis alcohol, tobacco, cannabis, other drug consumption history, hormonal status, whether it's perimenopausal, postmenopausal, or someone in transition between genders who may be taking testosterone, complaining of pain in the elbows because now they're generating more muscle with greater force than would be the norm for that gender. And beyond that, you want to know whether the patient is ergonomically set up, as you, Deborah, have said many times. You need to address ergonomics. You have to figure out whether the patient is, with English as a first or good second language, capable of doing voice recognition to offload a lot of hand use onto voice with a well-tempered, soft voice in which you train a voice profile so it's soft, not strident, not screaming, not straining the cords. And then COVID status, whether they're a survivor, whether they're currently COVID sufferers, which could be as simple as loss of taste and smell as opposed to flu-like symptoms and fever. So, because we've got this overlay of the viral pandemic. And so, frankly, if a doctor is not willing to figure that stuff out, and it's not an interrogation scene, but if they're not willing to figure it out, then maybe they should punt and send the patient elsewhere to somebody who really will take a tremendously detailed history before even touching a patient.
So that's the next question. How about the exam? Because really the fingertip to the shoulder blade exam should be done. So can you talk us through that?
Sure.
RSI exam?
Yeah, I'll tell you what I do in or out of a workers' compensation claim is get the patient to stand up if they're capable of standing. And then as Simon says, do this, do that, do this, do that, move through a full range of motion. I record all measurements, neck, shoulders, elbows, wrists, hands, and so on, to look for symmetry or look for something that might be a little stiff. Generalized stiffness in a type 1 or 2 diabetic is diabetic chiropathy. Figure out whether they're moving in a relatively small range of motion. So that's the range of motion stuff. And then I'll take grip and pinch strength. So measuring with the dynamometer. So that I can,
yeah.
Right. So I'm measuring grip, rapid exchange grip, so they can't. So I'm looking for consistency and also deficits. a pinch meter. So I'm looking for power of pinch, looking for symmetry, asymmetry there. So having looked at range of motion, having looked at grip and pinch strength, then the next step is to thematically divide the exam into primarily two categories. One, neurological. Two, musculoskeletal, anatomically discrete inflammatory conditions. One, nerves. Two, inflammation. And obviously they can run parallel, but just for the sake of completeness, you're talking about Sperling's maneuver, axial loading of the cervical spine to see if there is radiating numbness or tingling or pain, meaning cervical radiculopathy. You're checking anterior scalene, lower trunk of brachial plexus, gentle compression, not on carotid. And then compression of plexus beneath clavicle, pectoralis minor origin, to see if you have radiating numbness or tingling or pain, realizing there are 38 primary anatomical variations of brachial plexus with infinity between. Chance will favor the prepared school of mind that knows that. And then once you've gone to plexus, you start going downstream in the three peripheral nerves, primary ones, which are median. And before you get to carpal tunnel, you're checking for any entrapments at proximal level, then carpal tunnel. Cubital tunnel behind the elbow, ulnar tunnel at the wrist. You're checking for, surprisingly common, radial tunnel, and that's above and at and below the elbow to see if that's a problem, either sensory, meaning pain on the top side here and numbness, tingling, and or whether it's weakness in an advanced case of entrapment of the radial nerve, which is a positioning nerve to get you ready to go. And so you've checked the three peripheral nerves. You've also considered that there may be atypical crossovers called Martin-Gruber anastomoses in the forearm where things hook up. So it's not typical carpal tunnel or other entrapments. And so again, that's anatomical variation of nerve supply. You figure out sensibility, 2-point discrimination, ability to feel 2 points.
Is that the Sims-Weinstein?
Yeah, it could be Sims-Weinstein or it can be simple 2-point discrimination with a gradated caliper so that you can compare both sides of each digit and then both hands, and Sims-Weinstein as well. One or the other, actually. I don't often do both, but I start with 2-point discrimination. Next thing, you're looking for inflammatory conditions. That's the second parallel pathway of inquiry. And so you want to check, but carefully and gently, if it's in the neck, if it's in the suspensory muscles of the scapula, the shoulder girdle, and that'd be trapezius, superior, inferior, rhomboid, the things that hold you up and so on. Then you go on in look for intrinsic shoulder joint pathology, impingement, acromioclavicular arthritis, rotator cuff, those kinds of things. You're also looking at the elbow for lateral epicondylitis, tennis elbow, medial epicondylitis, golfer's elbow, intrinsic elbow joint pathology, biceps insertion tendonitis, triceps insertion tendonitis, olecranon bursitis. Then you're going downstream with all these kind of itises to just check. You're checking to see if they have congenitally long ulnas with impingement or abutment of a long ulna onto the ulnar carpus such that they were never fated to go. Caps lock, shift, tab, option, enter, control, return, escape, because they're beating up on a carpus with a long ulna. And so these anatomical variations of skeleton of muscle tendon units, you're going out and checking for trigger digits or tenosynovitis, tightness with irritability and maybe sticking, clicking, locking of these digits. You're checking the thumb ray for arthritis, most typically trapeziometacarpal arthritis, but other joints along the thumb ray can equally be troubled. You're checking for intrinsic wrist pathology, radial, central, ulnar side of the wrist. You're checking all the small joints, MCP, PIP, DIP joints for any problems. Could be arthritis, could be a number of things out there. And then you've got kind of a detailed picture of what's going on, meaning neurological assessment, and then looking for anatomically discrete inflammatory conditions. And besides that, lumps or bumps. I mean, I never forget that a patient who's complaining of RSI could have something maybe even scary going on. So I'm checking not only for thyromegaly, goiter. I'm checking for discrete palpable thyroid masses. I'm checking for cervical adenopathy. I'm checking for supraclavicular adenopathy, hard stuff, long-term smoker, lung cancer, metastatic to nodes. I'm thinking about lumps or bumps here or there. Unusual to have parallel cancers affecting the upper limb, but being around the block a few years, I picked up a number of sarcomas, things that required fairly significant specialty, MD Anderson, Sloan Kettering level, Mayo Clinic level. Better get this thing out of there. Yes, they've got some carpal tunnel, but here's what's threatening their lifespan. So, you know, you never want to be blind in RSI to thinking it all fits into an RSI basket. You have to think comprehensively without frightening the patient.
And this is why people need to see an MD.
Well, I think so. You know, sorry.
With this kind of broad knowledge that would look for something beyond that. Where would you put, and by the way, that was an amazing lesson in anatomy. It's so fascinating. But you talk about inflammation and other things, but where would thoracic outlet fall?
Thoracic outlet would fall into neurological.
Neurological.
That's entrapment of the brachial plexus. And that can be the classic sort of long isosceles triangle of anterior and medial scalenes through which the brachial plexus, usually lower trunk, runs and can be tight above the first rib. You can have an accessory cervical rib, contributory, and that's normally a pretty tight channel, but you want to check it with the standard thoracic outlet syndrome maneuvers. But you don't want to be blind to the possibility that it's tight under the pectoralis minor. And a lot of thoracic outlet surgeons have realized that maybe it's not so much there, maybe it's not so much first rib, maybe it's pec minor over top of the plexus. And some have just done local anesthesia, do a little fasciotomy, release pec minor. If they're better, they'll know it within hours. So it's kind of seasoned to taste with that diagnosis, but it can be significantly contributory and masquerade as peripheral entrapment neuropathy. But in fact, the big trouble's here. It's not easy to treat. These are forward postured people looking at a screen with a small tight face. And they have to straighten up and fly right, but can't do it suddenly because they'll tighten up too much. So postural therapies are certainly relevant, as are myofascial therapies and gentle stretches, some hands-on physical therapy, all done very gently to avoid stirring up a hornet's nest.
So how long did it take you to learn this? And if this is two parts, if you wanted to gain this kind of incredible knowledge and the ability to really dive in and give a good diagnosis for repetitive strain injury, considering all the multitude of things you just talked about, if a doctor were interested in that, would he or she apprentice with someone like you? Where would they go to learn this?
Well, it's on-the-job training to some extent. I encourage people to, if they have an MD and they're COVID and TB negative, they go into an OR with trusted surgeons in the region and watch a vascular surgeon decompress the thoracic outlet, watch a hand surgeon decompress a peripheral nerve. See, I was never shy in my training. Two things happened. I trained broadly and got to know, in a very positive way, colleagues in all surgical disciplines, so I could go and watch major fractures set, the dome open to take care of brain tumors, whatever I needed to know. Plus, I guess I had an added advantage because I had all the unclaimed dead under my wing in San Francisco from 81 to 89 when I ran hand surgery at SF General. And so the coroner, now deceased himself, but a good friend, said, these are unclaimed people. Would you want to dissect them? Which I did from head to toe, did thousands of drawings, and taught physical therapists, occupational therapists, surgeons, colleagues, med students, how to think about not just normal anatomy, but also anatomical variation, and again, thematically, form, function, fit, and failure avoidance. And so I guess I had a little plus, but I'm not, and I've been training young surgeons for almost 40 years on 2 faculties. So I enjoy teaching. Obviously, doctor means teacher in medieval English, medieval Latin, and what is it, medieval French, medieval Latin, and Middle English, same etymology. And so doctors should be teaching themselves and teaching others. There's no school that I know of that teaches just about RSI, because again, it's multifactorial, involving all the domains of medicine. But you have to keep studying, and you have to keep reading, and you have to keep thinking. No question about it. There's an exponential explosion of evidence-based, non-financially interested medical literature, and all the topics that you have to read. And right now we're in the involuntary acquisition of a massive, explosive immunology knowledge based on COVID viral pandemic. And so chance will favor the prepared mind. But I have enough survivors of all ages of the COVID epidemic that I've learned a lot about it, and also how to stay out of trouble personally.
Well, that's the perfect note to end on, because we want to have you back to talk about COVID. So I want to thank you so much for coming on and sharing your vast expertise. If anybody has any questions, especially medical professionals, and Dr. Markison is willing to come back, please put it in the comments box, and we'll see if we can answer them in a future episode of RSI Help YouTube. Meantime, thank you so much for watching. Thank you, Dr. Markison, once again. That was